But before I wait, I should wait. Espero?
Yes.
Can I check again?
Let me see. No,
Yeah,
It's good?
it's good.
All right.
everything going.
So, I guess wherever I left mid-thought, no, it's fine. I don't consider myself a leukoplakia expert by any means. I have colleagues that I work directly with, other colleagues within, the American, U.S. oral medicine world, and colleagues in other parts of the world who really are experts. They know the literature inside and out. They live and breathe leukoplakia. And for some people, I think getting to the bottom of what is leukoplakia, what can we learn about it, and how can we potentially predict, and how do we best treat, it's almost like a life mission. I don't have that mission. I find it interesting, I find it frustrating, and I try not to get too pulled in one way or the other. I don't want to say this the right way or the wrong way, but I think we're fooling ourselves to some extent if we think we can be magicians and see into the future when we actually can't see into the future, and/or that we absolutely can catch a cancer 10 years before it's going to be a cancer and potentially give that person 30 more years of life than they would have had otherwise. I think these are all pipe dreams. Maybe I've proven wrong in my grave at some point, and I'd be very happy if that's the case. And I'm sure we will learn more, and we'll be able to predict better, and we will have some better treatments with time. But I think, like most things in medicine, and again, I could be wrong, there could be a transformational shift coming, but I think these changes will continue to be incremental, little by little. So, you do something different, and now your patient does a little bit better. But I don't think that we're going to see absolute huge frame shifts in this field. Like I said, I would love to be proven wrong, and I think there's a lot of areas that have potential for change to happen. But the idea that if we somehow, because I think when we focus on leukoplakia, what we're really talking about is cancer. Nobody really cares. Like, if I have a white patch in my mouth and it's there for my entire life, who cares? Nobody looks at it. It doesn't affect my taste. So what we're really worried about is cancer, and we know that at the end of the day, you can diagnose a cancer earlier. You can diagnose a cancer at another point. Sure, it's very bad to simply ignore and miss a diagnosis, but in most situations, most cancers don't just hide. Eventually, they make noise, whether it's in the lung, the breast, mouth, colon, you name it. And I don't want to get too deep into this because I am by no means an expert on early diagnosis, lead time bias, and all these very interesting and very important concepts. But we kid ourselves to some extent when we think that all these screening programs and things like this make a huge difference. They make a difference, and they make a difference for some people, but in the grand scheme of things, most cancers can't be screened for, and most cancers will knock on the door when it's time, and they need to be diagnosed and treated. And catching something earlier, yep, you've lived with your cancer longer, so you've had a better outcome, right? Because instead of dying in 5 years, you've died in 25 years from your cancer. But it doesn't necessarily mean that we've provided a better treatment. And I think when we talk about being very aggressive with a condition like leukoplakia, there's so much we don't know that we're kidding ourselves to think that we understand enough that simply by, for example, treating a lesion and showing that it goes away for 6 months, that's actually the best thing in the grand biological, medical sort of scheme of things for the long-term outcome of that condition. We don't know. So, and I very much acknowledge that we don't know, And oftentimes, I think when you don't know something, it's actually better not to keep punching it and kicking it and spinning it, but just kind of let it be, because it's going to whisper to you, at least at some point, and tell you something. So that's my big picture philosophy coming into this. But I like the challenge, and I told Manuela when she came up with this long list of things for me to prepare for over 2 weeks, I said, okay, I'll do this one. And I was very well prepared. Up to about 4 weeks ago, I had almost all my talks ready. And the one that I kept pushing was this one. I didn't have a single slide, nothing. 4 weeks ago, only 4 weeks ago, maybe even 3, before I started doing a little bit of literature search, and then I fortunately, and other faculty here have good contacts. If I have a question about some laser technology, of course I'm going to reach out to them. I wouldn't expect that I know it. And same thing for leukoplakia. So I reach out to Suk and Wu, who I work with, and people around the world look to as a leukoplakia expert. I reached out to my former trainee and colleague, Alessandra Villa, also a leukoplakia expert, and Ross Kerr, New York University, also oral pre-malignant lesion leukoplakia expert. And I said, can you guys do me a favor and just the most important top, whatever it is, 2, 3, 4, 5 articles that you really think, I'm putting this talk together, it's about leukoplakia, what is it, how do we manage it? I want, what do you think are the most important, most recent, most significant papers? And then I got started putting this together. Of course, I didn't just use the recommendations that came from them. So I hope you find it interesting. It's very literature heavy, so it's going to open up a lot of doors for any of you who are interested. You can write down reference after reference. These aren't very esoteric references. Like I said, some of them are the ones that were just provided by my colleagues. And then I'm going to talk a little bit, when we talk about management, I basically have one slide, which will be the Cochrane review that says nothing does anything, we don't really know. I will show you another slide that's a fairly old slide now, but I think from a framework of how to approach the management of a patient with leukoplakia, it hasn't really changed from the early 2000s. And then I'm going to show you some work that has been done, I would say, rather than it being my work, which I would never take responsibility for, work that has happened and or is ongoing, both clinical trial research, also just clinical experience. So not even an open protocol, but just how some patients are being treated at our center and treatments that I've been involved in. And I think when I present those short stories, I am in no way endorsing these treatments. I'm in no way proposing that these are actually effective treatments. I am in no way proposing that these should be treatments that you here should be thinking about and or evaluate. It's just to get you thinking. And the reason that these treatments are being provided is because there are people that I work with within my division, within the head and neck oncology program, who want to see something move forward, maybe more than I do in this area. And so I'm very happy to share it, but again, I don't want it to come across as, you should be doing this, or, wait until you see what this shows in 10 years, because I can't tell you that that's the case. All right, no more introduction. I think this group saw this slide before, so just to point out where we are, where our clinics are, most of the patients we see with moral leukoplakia are at the Dana-Farber Cancer Institute, which is in Boston. It's actually very nice. Since we've had a designated clinic there, we've been able to focus our oncology-related patients to that clinic almost exclusively. And that's also opened up potential avenues for research collaboration. So there's actually a sort of a pre-cancer funded protocol throughout the Dana-Farber Cancer Institute right now. And we're collecting all sorts of data, including blood, on patients with oral leukoplakia. So we were actually just having a research meeting about this and talking about how for patients that we still have, that we might be seeing at the clinic at the Brigham and Women's Hospital, because some patients may be seen at either clinic, that it would be ideal to have those patients transferred to the Dana-Farber clinic so that they'd be eligible to participate in that protocol, for example. Good. So just so we're all on the same page, hopefully everybody agrees that these are all leukoplakias. Each one's a little bit different. Some are gingival, some are on the tongue, some are smooth and more homogeneous, some are more non-homogeneous, some are very well-defined, some are not so well-defined. But these are all leukoplakias, and all of these lesions underwent biopsy at some point and demonstrated some degree of abnormality, simply because they're white lesions, right? So they're at minimum hyperkeratotic, or what's been referred to as hyperkeratosis of unknown significance, or demonstrating various degrees of dysplasia. And the sort of dichotomy between dysplasia versus no dysplasia is something that I'm going to talk about a little bit during this talk. I owe much of that discussion to my colleague Suk-Bin Wu. It's her area of expertise. She's done a lot of really interesting work along with others in sort of better understanding and defining leukoplakia white lesions that otherwise don't demonstrate dysplasia, but that have high risk tendency or potential. And I think that's a really interesting concept that, again, from the standpoint of if I were asked to talk about management of leukoplakia, I took that very broadly because I would argue that part of managing leukoplakia is simply, what do you see through your glasses when you see the word leukoplakia? Because not everybody sees it the same way. So this was one of the papers. I knew this paper, but this was one of the ones I think all three probably recommended. This is Oral Potentially Malignant Disorders Consensus Report from International Seminar on Nomenclature and Classification convened by the WHO Collaborating Center for Oral Cancer. This is published in 2021, and it provides all the different definitions for the oral potentially malignant disorders, including the first one listed, obviously, which is leukoplakia. And my eyes are not very good from here, but I'm going to do my best so we can see. It says predominantly white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. And that resource goes back to the 2007 reference from 7. So again, here are two different leukoplakias. The leukoplakia on the right side, a little bit better defined, very sort of smooth, homogeneous. Leukoplakia on the left side has more of a sort of a corrugated pattern to it. Both buccal mucosa, obviously biopsy is going to be necessary for a more specific diagnosis. And so there's some caveats that that come from that paper and then the paper from 2007. Again, it can't be rubbed off. They have some considerations that most homogeneous leukoplakia affect a circumscribed area, well-demarcated borders. Non-homogeneous leukoplakias may be more diffuse and sort of less well-defined. Maybe they have some red component or sort of some bulky component to them, suggesting there's maybe a fundamental difference even between, the sort of the genetic characteristics of one versus the other. There can't be any evidence of chronic trauma in the area. It's not a cause of leukoplakia, and it's a different diagnosis. Can't be reversed or eliminated because of some cause, because again, we don't know what causes leukoplakia. You can't make it go away from stretching the tissue. And you've excluded any other lesions that would otherwise potentially be considered. And I'm not going to show you that table. Oh, I'm sorry. I won't miss the advance again. I had to forget once. But this was everything I was showing you. And I'm happy to make these slides, and any of the slides from everything, I'm happy to give you as PDF at some point, so if people want. So one thing I think is important if we're going to talk about managing a condition is how common is it, how prevalent, what do we know about it? And these are sort of best estimates because none of these studies are perfect, but there are some fairly large studies that have come up with some fairly consistent numbers. So there's the 2003 reference on the left side was one that I always sort of would always turn to for numbers. And in updating this, there was this updated report just in 2023, combining data from some updated studies as well. But they both sort of fall around this somewhere between 1% and 2% perhaps, which seems reasonable. I don't know if it's really that high. It's probably not that high, just because I think still a lot of things are getting called leukoplakia in these studies that may not actually be leukoplakia. But we know it exists, and we also know that there's no epidemic, for example, of leukoplakia. So obviously, we said we need a diagnosis. I can't tell you, and we'll see how you feel at the end of this talk, of how predictive the diagnosis is for what may or may not happen to the patient, or how you're going to use that diagnosis to potentially suggest, recommend, or provide management for a patient. But first, just getting a good biopsy obviously is important. So you can see on the left side, this is obviously a mixed red and white lesion. Should be concerning. Just looking at it, it's really not at all a leukoplakia. There is leukoplakia components, and there's a more distinct leukoplakia on the right side of the tongue. But in this case, I actually obtained several biopsies so that I have really a good sample. And I'd say in any case where we're dealing with a really non-homogeneous lesion, and especially if there's really distinct features, probably a good idea to get at least more than one. I can't tell you need more than 2 biopsies. In this case, I like the idea, especially if it was going to be, especially if I was expecting that I was going to then refer this patient for surgical management, that there would be some understanding of sort of what are the characteristics in all these areas, so the surgeon could be potentially more or less aggressive. And then this is after a biopsy on the other side of the slide, obtained from right in the middle of what seems to be fairly characteristic changes for the whole lesion. Post-punch biopsy with silver nitrate. I think use silver nitrate here after a punch biopsy. So after a punch biopsy, you always place a suture. So try silver nitrate. It will cut down your time with the patient by at least 5 minutes. And it's the easiest thing to use. It doesn't leave a mark. It makes no difference compared with suturing. So in this case, we biopsy the patient, and for the pathologist in this room, there's some degree of dysplasia here. I wouldn't try to grade it one way or the other, somewhere within a mild to moderate dysplasia. There's not a whole lot of inflammation, so it doesn't seem to be a whole lot of reactive changes. You see hyperkeratosis, all consistent with this being a white lesion. But sometimes we don't have dysplasia. Sometimes we just have hyperkeratosis, or we have acanthosis and hyperkeratosis. And you see in this case, this is the same lesion I showed you before. And in this case, the biopsy shows actually a much thinner than normal, so an atrophic epithelium, right? It looks very thin, but the keratin layer is very thick and somewhat abnormal appearing. And again, there's no, here's the dysplasia. I'm really not good about working with these two systems. So again, here's your dysplasia, mild, moderate, not severe dysplasia, hyperkeratosis, very minimal inflammation, there's some inflammatory cells. This case is the one I showed you previously, and here's where you can see in the biopsy you have a much thinner than normal, so it has atrophy, but a very, very thick keratin layer. And this is obviously, it's a very abnormal growth pattern. And there's really almost no inflammatory cells in the connective tissue. So it opens up a lot of questions and a lot of areas to potentially, for exploration and research, is actually understanding better what is the makeup, the molecular, genomic, mutational makeup of leukoplakia. What do we understand? How do these different findings actually drive various features of the disease? And a number of there have been a number of excellent studies, and I'll show you a few that have given us more insight into this. And you can see also on the right side the from World Workshop Oral Medicine 7, talking about prognostic biomarkers in leukoplakia and proliferative leukoplakia. This was a systematic review, but again, trying to find ways to be able to identify not just from histology, but also from molecular analysis, what is different about one versus the other, and how can we potentially use that to assess risk. And again, just talking about leukoplakia and making sure that we all agree on the same thing, the concept of proliferative leukoplakia or verrucous leukoplakia or proliferative verrucous leukoplakia, there's no question that there is a condition in which leukoplakia behaves differently than other leukoplakias. And we definitely can see leukoplakias that extend and sort of grow and expand over time. But how to exactly define this condition, I think still remains a bit of a question. And every time you try to define it more specifically, it almost creates more problems by the definition. But some patients will present with multifocal leukoplakia, and in some cases that leukoplakia will not just be a nice, smooth, homogeneous leukoplakia, but will have the sort of corrugated verrucous features to it. And so this was a paper published in 2021 titled "Proliferative Verrucous Leukoplakia: An Expert Consensus Guideline for Standardized Assessment and Reporting." So this is based on both clinical descriptions and histopathological descriptions. And again, for any of you who are interested, I think a really important and interesting paper to read. And this is just an example of one of many patients that I've had or have who have multifocal leukoplakia. I sort of chose this one specifically because it's a little bit unique. It doesn't have some of the gingival lesions that we often think of when we talk about proliferative leukoplakia. But obviously, if we're worried about risk and we want to potentially have a treatment, if we were convinced that removing leukoplakia could reduce risk of potential malignant transformation, you could imagine that this would be a very difficult patient to try and achieve that as a goal, regardless of how you're going to try and treat the patient. But what's as or more frustrating for those of you who know enough about this and or have treated this condition is that while there's an increased risk of cancer, cancer can develop in areas where there's no leukoplakia. Cancers can develop in areas that seem to be lower risk leukoplakia versus other areas. So again, the goal of treatment when you don't exactly know what the risk is really difficult. Here's another clinical example. This is a patient actually I did the lower pictures. I just saw this patient last week, I think, for follow-up. I see her once a year. She has a history of lichen planus in the background of this leukoplakia that's developed. And I show that first image because if you look on the upper right, you see that big ulcer. That's, it's active lichen planus at the time. Or at least as best as we understand. I mean, she's been diagnosed previously with lichen planus. She has lichen planus features, and in this case has inflammatory ulceration that can come and go. But this is, I think maybe from top to bottom is maybe 4 years or 5 years. Lichen planus has not been as active. In the area that used to be ulcerated, you see a lot of sort of bulky white changes. And the area of, let's just say, proliferating leukoplakia on the tongue has become sort of more extensive and sort of thicker. But, what can I do in this case other than see the patient on occasion and biopsy areas that I think perhaps are of concern? If I see an area and it hasn't changed largely from a year before, I'm not really sure what I'm going to achieve by biopsying it when the only treatment would be a massive surgery. And if there's not a cancer, we're not going to move ahead with that kind of treatment. But I should just, again, I think a few things that you can take away from this are one, you can have more than one diagnosis at the same time. Things can change over time, and the importance of getting good photographs can actually be very helpful. Just to be able to reference back to what you saw a year ago, 2 years ago, or 3 years ago. So, obviously, this is a really important question because it somewhat guides our level of concern, how we explain risk to the patient, and how ultimately we try and make good clinical decisions. So this was an article published in 2016, systematic review of observational studies looking at malignant transformation of oral leukoplakia. So these are not, we treated all these patients with surgery and here's what happened. This is just, follow these patients and let's see what happened. Based on the inclusion criteria, there were 24 studies included. And this is sort of the takeaway on the right side. They say that the estimated overall mean malignant transformation rate for the total population described in the 24 studies was 3.5%. There's 405 patients out of over 11,000. But there was a wide range across studies, ranging from anywhere from 0.13 to 34%. A 34% transformation rate, it obviously suggests a very sort of selected and biased population of patients with leukoplakia. And I don't really know how to explain or justify the 0.13 on the other side. It may be that that's more accurate or even less than that, I don't know. But from all the studies, they were able to tease out that there were risk factors associated with malignant transformation, and not surprisingly, advanced age. Female sex. I think female sex largely because, again, if we use the term proliferative verrucous leukoplakia, it is a condition that is encountered, at least we understand, more in women than men, and that's a high-risk condition, so it may be, I don't know. Lesions that are larger in size are higher risk. Sort of makes sense. Non-homogeneous features, we already talked about that, increased risk. And then the presence of dysplasia, and also higher grades of dysplasia. And this is a table from the paper, and this is a table that shows a subgroup analysis of transformation rate to malignancy based on the epithelial dysplasia grades. And I think if you follow along really on the far right side, you can see study by study where they actually these are the studies that were included that had separate grades of dysplasia. And you can see that there's fairly consistent higher rate of transformation in higher grade versus lower grade dysplasia. This is another study done also very recently, looking at malignant transformation rate of oral leukoplakia over 20 years, a systematic review and a meta-analysis. And again, I just highlighted this figure that shows, based on varying degrees of dysplasia, there being increased risk. So this is where I think the story starts to get a little more interesting. And again, I don't take responsibility or credit at all for this work. You can see this was when Alessandro was with us. Alessandro, first author, Sukbin, who last author. I wasn't even involved in this study. But this was looking at the genomic characteristics of oral keratosis of unknown significance. So they identified a large, I don't remember the sample, a large sample of cases, very well characterized of KUS, or keratosis of unknown significance, and also oral dysplasia, and looked at the genomic characteristics, and essentially found that there were actually some really significant similarities, despite the fact that one group is showing dysplasia, the other group is not showing dysplasia. And then Suk and one of our former pathology residents, who's in Cleveland now, published this study. They reported on the malignant transformation rate of non-reactive oral hyperkeratosis. So again, essentially, I would say a new term for keratosis of unknown significance, and suggesting that this alone, without actual dysplasia, would be a consideration of an early dysplastic phenotype, because they look at, and I know it's kind of hard to follow all this, but I think the columns that are most important are, if you look at the third column over, incidence of malignant transformation of non-dysplastic leukoplakia, and then the next one to the right is the incidence of malignant transformation of leukoplakia showing dysplasia. And the rates are certainly lower in that first column because they're not dysplastic, but they're also not zero. So, yes, dysplasia seems to be higher risk, and we know that from some of the other studies, but these are not zero risk lesions in their own being. These are a couple of slides that when I sent out my SOS to my colleagues, I fortunately have very good friends. Suk, started sending me things immediately. She sent me these pictures. She sent me some slides that she's been using in a lecture. So I very much appreciate that these slides came from Suk. These are two cases of whatever we call it here. We'll say non-reactive oral hyperkeratosis versus keratosis of unknown significance. Sorry, I'm going to get back to my slide. That subsequently transformed to squamous cell carcinomas. So these are the earlier lesions and then the subsequent malignant transformations. And this is a really nice paper for any of you who are interested in this, and for those of you who are actually studying pathology. This was, again, with Suk and one of our former, actually two of our former residents in oral pathology. So this is architectural alterations in oral epithelial dysplasia are similar in unifocal and proliferative leukoplakia. And these are these architectural versus sort of classic dysplastic features that they describe. And they looked at sort of like simple leukoplakia versus the more complex leukoplakias. And these are some of the features that that they highlighted from architecture that she has highlighted here. But there's architectural features, there's organizational features, there's cytologic features. I don't want to go through this in detail. I'm not a pathologist, but I do like the figures a lot. So I'm going to go through just so you can see some examples of what they showed. So for example, here, this was unifocal, non-homogeneous leukoplakia, and it's showing, sort of atypical verrucous hyperkeratosis. You see both the clinical and this classic histopathologic feature. Here's another lesion showing this very bulky verrucous proliferation with exo and endophytic components. So again, one of these features that they describe. This is one with hyperkeratosis and epithelial atrophy, like that case I showed earlier from the right buccal mucosa, where you have the thinning of the epithelium with the really thick hyperkeratosis. I think I remember when we had that case, she was really excited about it because it was sort of early on in her journey to start putting this story together. That's a great case. I'm sorry. So this is the first one I was showing you. Anybody who thinks proliferative verrucous leukoplakia, close your eyes, think about it under a microscope. I think this is usually what we expect to see. This is the one that has these really bulky, sort of both exo and endophytic components. This was the one, like the case that I was telling you, like the one I showed you from the right buccal mucosa, that just shows the really thin epithelium with the really thick keratosis. This one also showing a bulky exophytic proliferation. So it's really thick and it's just like, looks like it's pushing outwards. This is one with what are referred to as skip lesions. So where you see it, that keratin like just start and stop like that, and then start again. This is showing atypical verrucous hyperkeratosis with epithelial atrophy. And again, all these cases I've shown you so far, none of them would qualify as mild, moderate, or severe dysplasia based on sort of classic dysplasia criteria. And then this is really interesting. This is when I got to sort of dive into the pool on my own and start exploring, and when I came across this literature, and actually had some discussions with Suk about it afterwards. So this is another group that has been doing some similar work. They call it this differentiated dysplasia, which is essentially their way of saying it's dysplasia, like these features that they showed in that paper, without the classic features of dysplasia. It's just different terminology that's being used by different groups. And this first curve is looking at malignant transformation rate, excuse me, of epithelial dysplasia versus differentiated dysplasia. So you have these two different groups here. And then this next slide, the next panel here is just working with dysplasia or no dysplasia, but all leukoplakias. And then taking the ones that did not show dysplasia and separating out whether they had features of what they call differentiated dysplasia. I don't remember off the top of my head what features would remain qualified for the blue line that sort of just doesn't transform. But there's, it was a leukoplakia. But you can see that, just when they separate out those differentiated dysplasia features, there's significant difference in the transformation rate. And then I need to look carefully and remind myself when we're seeing my eyes. The screen is small.
All included cases.
Yeah, all
included cases.
I can't see.
Stratified for absence, blue, or presence.
Absence or presence of any type of dysplasia.
Yeah.
Okay. Right. So big difference there. All right, so I said we're going to have at least one slide where we actually talk about management. And I can't be smarter than the experts who did a Cochrane review looking at, what's the best evidence we have. And I'll just look at the things that I highlighted. There were only 14 studies that met the criteria. So just because there's lots and lots of interesting case reports, we can't base an evidence base on that. So 14 studies with over 900 participants. They included surgery with laser, cryotherapy, surgical intervention, including laser therapy and cryotherapy, have not been studied in a randomized controlled trial. So what we think of as sort of the most standard treatments that patients would undergo for this diagnosis, we actually have no randomized controlled trials. We don't have, and even those randomized, even if they existed, again, you would need so many years of follow-up and so many numbers of patients to actually demonstrate that you prevented something. And we don't even know the malignant transformation rate. We don't really know it. So you're aiming at a target that is constantly moving, and you don't even know exactly what you're shooting at. It's a really challenging clinical situation. And they say, so in general, we judge the overall quality of the evidence to be low or very low, so findings are uncertain and further research is needed. None of the studies provided evidence that active treatment reduced the risk of oral cancer more than placebo. Some studies also reported a high rate of relapse, meaning you did this, great, but if you follow them long enough, it just comes back. And again, when something leaves and comes back, sometimes it comes back angrier, stronger, and more upset than if you just left it in its room and kept feeding it. You have to think about that. We don't know. And then this was sort of more of an opinion piece that came out from a conference, again with Ross Kerr and Gia Lodi, talking about management of oral potentially malignant disorders. Bottom line is we don't really know what to do. They just reiterate from the Cochrane review. But they have these nice tables that talk about some of the research questions around management of patients, things to be potentially looking at, asking about, research questions about surgical management. So again, I think for those of you who are studying, learning, great paper to read just to get you thinking. And then this, I don't remember who sent this to me, but this was, it's early on, it's a small study, but at least there is a group in Italy that is doing a randomized controlled trial looking at the efficacy of surgical excision, in this case of non-dysplastic, so let's say keratosis of unknown significance, differentiated dysplasia, whatever it is, to prevent oral cancer. And I don't remember off the top of my head what the follow-up is at this point, but essentially they have, they've had one individual in each arm that has developed cancer. So not much we can say other than at least somebody's trying to do something to add some evidence base, and I commend them very much. So this is this was the management slide that I referenced before. I'm sure you're familiar with this paper. Again, I've used this, in giving talks about management of white lesions and/or cancer. I've, at least since 2002, presumably been using this figure. I think it's nice and simple. So you have a diagnosis. You have a patient with leukoplakia. You've gone through. You've ruled out that there's no possible cause. You have a biopsy. This is all on the right side. The left side is sort of less significant. And biopsy will show you it's non-dysplastic, it's dysplastic, or it's some other definable lesion. You biopsied it, you didn't think it was going to be that, but it's something else. Okay, well, I can treat it differently. And then the recommendations, if it's non-dysplastic versus dysplastic, they're a little bit different, but they're not tremendously different because, again, you don't really know. So I think it's a good framework. My guess is most of us that deal with oral leukoplakia more or less follow this algorithm because it's logical, but it's nice and simple. So here are a couple of patients that actually didn't include the post-surgical follow-up. They have beautiful results in both of them. But these are patients who come from, let's just say, very different medical backgrounds. It's not worth getting into. Both presented to me initially with some degree of what I would consider a risk, a high risk lesion. The one on the bottom, I don't want to jump too far ahead because I'm going to talk about the study where we actually treated patients with nivolumab with high risk leukoplakia. And this was a patient who was on that study, did not have a response. I continued to follow afterwards. And as this lesion kept growing and progressing, it got to the point where I said, you know, I always have a very frank discussion with my patients from the start, how aggressive they want to be, how aggressive they don't want to be. I'm as honest as I can about how well I can look into the future or not, how we're going to approach this. So I think, you know, patients understand me very well. This patient, he's had this for a long time before he ever came into our practice. So he knows. But as this got bigger and bigger, it got to the point where I said, you're going to have surgery. Like this is at some point, even if this doesn't become actual cancer, you're not going to be able to live with this. I mean, this is a problem. I can't tell you that, you know, surgery is absolutely going to stop this from redeveloping somewhere else, but I don't think we can just keep sitting on this, despite the fact that there's no cancer diagnosis at this point. The upper one is actually a stem cell transplant patient, and developed this area. Initially, just almost looked like some chronic graft-versus disease changes, but it was clearly like very isolated and irregular. And then over time, just kept kind of growing and expanding. Again, having this discussion with him about what are our options. Especially when it's a case like this where the gingiva is involved. The only way that you're actually effectively going to be able to remove, if you want to manage surgically, is like a cancer surgery. It's going to be a block resection. You have to remove teeth, periodontium, bone. So it's a major undertaking. And the question is, at what point, if you don't have a cancer diagnosis, do you both agree to, we say pull the trigger, make a decision, and move forward with surgery? And in this case, it just kept expanding and started expanding up into the buccal mucosa. I think we'd already gotten a diagnosis of moderate dysplasia. And I just said, I still can't tell you what's going to happen here, but I know you don't want to do it, but I think you have to have surgery. And so we'll keep following these patients, but really, really nice outcomes in both cases. And then these I can show because these are within my neighborhood of comfort, so to speak. So, and we were talking yesterday about sort of a surgical approach. I like to use an inking pen to mark my sort of outline before I go and excise a lesion like this. And I'm generally very conservative. And you can see in this lower one, I have maybe a 1 millimeter margin because I'm not going for wide margins. I just want to clear the lesion. I already have a diagnosis. I've already done a bunch biopsy previously. And I know I'm going to follow this patient carefully. So I don't really see what the benefit is of potentially taking a whole lot more tissue. I'm never going to consider, I don't know how to graft. So if it's large enough, it gets to whatever point, I'm going to have to refer the patient for grafting. For these, very comfortable. But in both cases, no recurrence. So just to show you, I can't give you any evidence base for this, and I have no idea what was ever going to happen with these lesions. But they were both high risk enough cases with degrees of dysplasia, and in both actually fairly high risk patients. This is a patient, also fairly high risk patient with chronic graft-versus-host disease, who developed this irregular dysplastic lesion, demonstrated moderate dysplasia on the lower lip. And we excised, there were positive margins. So moderate dysplasia with some otherwise generalized changes along the entire lower lip. So we opted, again in discussion with him, opted to do post-surgery topical chemotherapy with 5-FU, 5-fluorouracil, or FUNEX. And you can see, this upper right is sort of at the height of the blistering phase. It's a really miserable treatment if any of you have experience having put a patient through, but we do it on the lip sometimes. And then he had wonderful recovery. And fortunately, there's never been any recurrence in the lip. I've been seeing this patient for probably over 15 years. Also, just providing information for patients is really important. So we have a patient with a diagnosis of leukoplakia. We have information sheets we provide this for. Any of you, you could go to our website and download this. There's other resources, available internationally. But we try to explain things as best as we can to the patient through the literature. So these next few slides, this is where I'm going to kind of go off a little bit into the deep end. Again, I'm not trying to guide you anywhere. I'm not trying to convince you that anything that I'm going to show you is spectacular, going to make a difference, or actually, in some ways, truly advancing the field. But it's some interesting work, and again, it's happened either patients that I'm also treating or patients sort of within our service. So I think the starting point for the first thing I want to show you is this paper describing treatment of what was called eruptive squamous atypia, or eruptive keratoacanthoma, and being treated with intralesional 5-FU, so a localized injection, not an infusion of 5-FU. And then similarly, this reference on the right side, I don't remember the number of patients, but they describe a large retrospective series out of their practice, it's a group practice, in which they had very small cancers in areas where they really preferred not to do surgery because of potential defects and deficits, and started treating these patients with intralesional injections of 5-FU, and with good responses. So these are two different cases that have been treated out of our service. Patient with, you can see the top one, patient has moderate dysplasia. Bottom also has moderate dysplasia, and these patients were treated with intralesional 5-FU. And here's what I can show you so far. So in the top, you don't see a huge amount of change. In the bottom, it's still sort of in it's still an ulcerative phase. So these are all just happening recently, and I think we hope that with over a period of time we accumulate some just evidence, experience with a certain number of cases, and then we'll be like all the other groups that have done the same. We'll do a retrospective report. It'll be an honest report. Everyone who's treated will get included, but it wasn't a research study. They weren't necessarily all been treated in exactly the same way. It'd be interesting to see what happens. But again, even if both of these showed amazing clearing, and I was showing you 6 months afterwards, I would not be up here on this podium saying, "Isn't that amazing? Isn't that great? Like, look what we did." Because I don't know that we're actually helping the patient. And then these are slides. Also, this is all retrospective. So we started collectively treating a number of patients with topical leukoplakia. We're not the first to have come up with this. It's been reported by others, just to get some experience, see how patients tolerate it, see what we actually observe. For those of you who were at the AAOM conference last year, our resident, Dr. Alpadla, presented. So these are from some slides that she presented and provided me with. So again, even my residents are my friends, which is really nice. Oh, use any slides you want, but I give her all the credit. It's a 5% crate that we use. I can't tell you that I know that. I understand that much about what the molecule is, but we know that it sort of stimulates immune reactivity in very specific ways through toll-like receptor stimulation. And this agent is FDA approved to be used topically for genital perianal warts and actinic keratoses and very superficial basal cell carcinomas. And you can see the regimen that was followed. The regimens that are followed for those three approved indications. And then what in the literature has been reported for oral leukoplakia is not tremendously different. And these are some examples of patients, their clinical conditions, and then being treated. So we limited this to gingival lesions, palatal lesions, anywhere that we could use a stent and actually, apply the treatment. What we would intend to be is sort of in as safe of a manner as possible, and controlled of a manner as possible. And then this is the follow-up data from all the patients who were treated. These were patients treated both in Boston and also in San Francisco, because Alessandro Vila was doing some of this work with us, then brought this sort of, again, I don't want to call it a protocol, but it was a clinical protocol we were following. No patients developed squamous cell carcinoma during or after the treatment and follow-up period, which is great for what it's worth. And you can see there's a large proportion that were considered sort of at least stable without obvious progression, and a significant number that had complete resolution, but at least at the follow-up period, so starting at 6 months, you can see 2 patients, the light blue, had recurrence after treatment, and then they were subsequently treated again. And here is an example of a patient who had a very good response. So you can see before treatment, during treatment, it almost looks like a little bit more aggravated. And then after treatment, and 6 months afterwards, or I'm sorry, 8 months afterwards, remains clear of lesions. Another one, before treatment, during treatment, gets maybe a little smaller, but also a little more defined. You can see some erythema, just reactive changes. And then after treatments and 9 months after, of course, we like to show you the really good ones. And then this is one who, again, before treatment, after treatment, and then at 10 months, there's a recurrence, and then treated again. Patients that were treated with this, with topical imiquimod, did have adverse events. You can see there was, most patients had some degree of localized toxicity, 84%. Most of it was just discomfort, sensitivity, in some cases frank ulceration. In some cases, flaring or maybe uncovering of underlying lichen planus or lichenoid inflammation. Some people had more distant toxicity because it was getting into the saliva and then swallowing saliva. And some actually had systemic. Over 50% would report fatigue, headaches, chills. So I mean, this is not and we were trying to deliver this in the safest way possible. So just to keep in mind, it's not the most benign of treatments, even though it is a topical chemotherapy treatment. And here's some examples of toxicity. I had a patient like the one on the lower left, where the whole soft palate was ulcerated at one point. We had to kind of talk about how it was being applied and ways in which maybe we could try and control it a little bit better. So that's so we talked a little bit about the intralesional 5FU. We talked about topical imiquimod, and then this was actually a clinical trial. So this was a registered clinical trial. We actually had funding from the drug company, makes nivolumab, and this work again was led by Glenn Hanna, also with Sukun Wu, also Alessandro Vila were very involved. Glenn Hanna was the overall principal investigator for the study, the one who secured the funding for the drug company. This data has been presented at the European Society of Medical Oncology, and the paper is going to be published in JAMA Oncology within days. So actually, there were certain things that gave me some materials to work with. We said, you can't share this with anybody because it hasn't actually been published yet. This is all been reported. Um, so this was a phase 2 study, again, 4 doses of nivolumab in patients with what was considered high-risk oral leukoplakia. And it's just the study design. These are adult patients, no prior immunotherapy, essentially people who are in otherwise good health. You have to biopsy the lesion. Need there are criteria, so diagnosis of what was considered high-risk oral leukoplakia, you can see at the bottom. And some people would agree more or less about how important these different criteria are. I'm not sure it's worth going through in detail, but there's a number of different criteria that were all considered for high risk. And again, we're saying high risk when we actually don't really have a good way to assess risk. So we have this inherent bias that we're only going to select these patients that we think are higher risk. And I'm sorry, and you can see this, the primary endpoint was leukoplakia regression, clinically and by biopsy. So again, the primary endpoint is not we follow these patients for the rest of their lives and find out do they develop cancer or not. But also some important secondary endpoints around safety, tolerability, and so on. And some exploratory endpoints looking at various immune markers, especially from the standpoint of are there ways to actually predict in a patient if ultimately this were to prove to be an effective treatment. Do we have a way to actually identify who's going to be more likely or less likely to respond to immune checkpoint inhibitor therapy? So there were some cases that you can see there's just no change whatsoever. The ones on the left all progressed and developed cancer, and the ones that sort of got improved, you can see, had various rates of overall improvement, so to speak. Some of these patients had prior histories of cancer, so I mean these really were a high-risk group because if you look at our numbers, the transformation rate within a relatively small study over a short period of time is actually a little bit frightening. But I think there's ways to explain it. Again, my takeaway from this is not the future of managing leukoplakia is going to be with nivolumab or some combination of immunotherapies. But even when you think about immunotherapy, we're still in the earliest days of immunotherapy, despite the fact that it's been in oncology practice for over a decade. All of the new agents that are coming in, targeting all these various aspects of the immune system along with sort of the bigger immune checkpoint inhibitors, just imagine that the amount that can be sort of tailored and targeted for a given individual's cancer 20 years from now, we'll look back to what we're doing today and it will be like, wow, this field has just come so far. So even in this study, we may be looking at this in such a rudimentary way that in the future there will actually be more effective ways to look at this and potentially manage. This is looking at, this is for, I think, the relapse on the left side of development of cancers, no CNS probability. So I didn't have the figures from the paper here with the with the legend. I know on the right side these are all various factors that were more highly associated with a response, and interestingly and not surprisingly, the PD-L1 CPS score. So looking at sort of what is the how much positivity is there when you would expect there to be an immune response. There actually is. I mean, unfortunately, we know that for a number of studies, just because you don't have a high level of expression doesn't mean that there won't be a response. So in some cases, if you use that too literally, you may actually miss patients who would potentially benefit. Not surprisingly, the only thing that seemed to put a worse risk was having a history of smoking. And then I don't want to go through this in any detail. We've already used enough time. But this was some additional sort of secondary analyses looking at immunologic correlates of both response and survival, both in the tissue and in blood. And looking at molecular correlates of both response and or survival, whether a cancer developed and or didn't develop. So, covered a lot of ground. I thank Manuela very much for allowing me to become smarter about leukoplakia than I was even 6 weeks ago or 4 weeks ago. But the takeaways, I think, don't change a whole lot. Oral leukoplakia is a heterogeneous diagnosis. There's no one leukoplakia, and the prognosis remains enigmatic no matter how much we think we understand, how much we can explore and uncover. Risk stratification is based primarily on clinical and histopathologic features, but much of that is still not so well understood or characterized. We're certainly moving towards molecular, but we don't really have reliable molecular markers at this point consistently. There's a very low evidence base that supports any and/or any specific intervention. And again, it's not to say that surgery, it's not to say that management of cancer isn't effective. We're not talking about management of cancer, we're talking about management of leukoplakia. And research is really important. I think we talked about a lot of different things that you could potentially think about in conducting research in this field. But for a lot of reasons, down to definitions, what are you dealing with, what are you asking, what are you trying to show, and even the risks of intervention and what that may do to the natural course of the condition, I would say, by all means, consider research in the field, but you've got to proceed with caution. And I'll stop there. I hope it was interesting, not too boring, not too much of a rehashing of old things that everybody knows. And again, really, those things that I showed you that we're doing, I think they're interesting, but I'm not overly excited about any of it.
So, thank you.
Lights.
Professor, thank you for your presentation. It was very, very nice and very provocative. I have here a question from the YouTube. In the clinical practice, is there some factor that suggests to you the indication of early surgical intervention, thinking in the risk of malignant transformation?
So I would say the best examples are those two cases that I showed you, where I referred those patients for surgery. I don't think there's anything early on except for grade of dysplasia. So if there's a really small lesion, when patients say, I don't care, I'd like to keep an eye on it, and you biopsy it and it shows severe dysplasia, I think you'd be crazy not to excise it. Now that's again, we don't know that it's actually the best thing, but I mean, historically, if you don't do that, I would say that you're practicing outside of the norms of the field of oral medicine. A small lesion this big, severe dysplasia, and to say, oh, I'm just going to keep an eye on it. I would just say, no, you should excise it. But what about a mild dysplasia that involves 2/3 of the tongue? So, you've got to be practical. And I don't have any experience with laser, so I think sometimes it's like, oh, well, maybe it's a little bit easier. Maybe the patient recovers a little bit better. Maybe it's a little bit cleaner of a procedure. And there was a lot of interest in that, of course, in the 80s and 90s. You don't see a whole lot published anymore. A lot of those, longer term follow-ups, you have, lots of cases that recur, cancers that still develop. So, I can't really say what the best approach there is. I think just being practical. Like I said, having a really honest discussion with your patient, explaining what you know, what you don't know, what we know about the field, and having them have some role. Because those two cases I showed you, where we kind of watched for a while, and I was like, okay, now it's time to have surgery. If there was a third case, there may have been a third case that on the first visit, based on what I explained to them, they may have said, all right, I want to have surgery. And I would never tell them, no, that's not the right thing to do. So, I hope that answered the YouTube question.
It's from Leandro.
Oh, he already knew the answer.
But even with laser, when it's available, it's not available for all, we have the disadvantage of not having material for histopathological examination.
Right. We can get up right to biopsy first. I mean, that's the other thing. With some of these cases, I've had. So without going into more detail, I don't remember the lower case, but the upper one that was sort of a smaller left buccal case. We had moderate, maybe in biopsy, moderate with focally severe. I don't remember exactly off the top of my head, but it was one of these cases that within the full resection, there was focal squamous cell carcinoma. But that's kind of like the needle in the haystack. You can't, especially if things look relatively homogeneous. You've sampled an area that's high risk from a visual standpoint, and you've gotten sort of a high risk feature back. There's always the potential for sampling error, which I think also is if it's high enough risk based on sort of classic dysplastic features, you're sort of obligated to do something.
But you can use the laser just to remove, not for vaporization.
Yeah, it can be done both ways. Yeah, you can do a surgical incision.
Vaporization you can use for.
Yeah.
And nowadays in Brazil, I know that Alan is conducting a clinical trial with Fabio, and we are getting in the study now, conducting a clinical trial to compare the excision of these lesions with laser and with scalp biopsy.
Yeah.
They are trying to do the.
But I think probably the most important endpoints there will be much more about like time of the procedure. Like what was the duration of the procedure? What were the costs associated with the procedure? What was the post-operative experience from the patient standpoint? How much pain medication did they require? How, and then of course recurrence. But I mean, the study can't be, did this prevent cancer better than the other? And there's no way that one's going to be better than the other. It's just, like biologically, why would it be better?
It's just a matter of the surgery.
Right. So, I mean, of course, I'm being dismissive, like how could it be different? But it's just, sometimes you have to question, like imagine you really want to do that study, you're going to do it internationally, somehow there's a drug company or a surgical company, a laser company that says, we're going to put all of our money on the table. Marco played poker last night. We're put all of our money on the table, right? All of our money on the table that not only is surgical laser or ablation laser, the answer to this clinical problem, but it's our laser that's going to do it. So somehow we're going to fund this study. It would just be massive.
Any question from the audience?
She's like,
Chega até pra
you can do it
Acho
in
que
the
esse não
camera.
aumenta mais que isso. Acho que esse não aumenta mais que isso.
First, thanks for the lecture, it was amazing. Maybe this question is kind of basics, but as you mentioned yesterday, each case is very unique. But I had this patient in the clinic. I don't have very wide experience with leukoplakia. I just had literally this one patient with leukoplakia in the clinic. But he was a very heavy smoker. He smoked like 2 packs of cigarettes a day. He was smoking for 30 years, and he had leukoplakia on the hard soft palate, like the transition. He had 2 lesions, and I performed an incisional biopsy with Professor Laura. I don't know if she's here today. she helped me in the clinic, and results of the histopathological diagnosis it was not dysplasia, it was
Hyperkeratosis, unknown significance.
hyperkeratosis.
Like we talked
Actually, it was hyperplasia. Yeah, I believe it was hyperplasia. And it didn't show dysplasia. That was the important thing. But so we just
But again, from the standpoint of those papers I showed you, some pathologists would consider that architectural dysplasia.
oh, they considered this.
They would consider that to qualify as like differentiated dysplasia.
Okay.
Because you don't see the classic dysplasia, but the structure is dysplastic.
Okay. So we just didn't consider dysplasia, and she said, just let's just keep on going and let's just keep following him up.
Yep.
And he's still my patient in the clinic, and I just keep looking at him.
Good.
So the thing is, the question is, how long would you wait? I know that she showed us a diagram, and it was saying that when it's not showing dysplasia, something between 6 to 12 months is the right time
Yeah.
to keep following up.
But no, so now you have to realize that paper was written in 2003, and in 2003 there was not this concept of other potential forms of dysplasia. So I would argue that, if you drop into this bucket and it's 3 to 6 months, and the other bucket is 6 to 12 months, it's a little bit of all the same. Like,
Okay.
does anyone really need to be seen every 3 months? It's probably a little bit too frequent, but we do it. You know?
Yeah.
And what's the difference between 3 and 4 months? It's only 4 weeks. But at that point, it's only 8 more weeks to 6 months. How much different is 3 months versus 6 months? Imagine you even have a cancer. How much does it matter? We're just talking about a cancer, not did you go to severe dysplasia. If you have a cancer, how much does it matter if you make the diagnosis at day 0 or day plus 30? Probably doesn't make much of a difference.
Okay.
1 year, 3 years difference, yeah, it starts to probably matter. Cancer is going to get bigger, the surgery is going to be that much more complicated, there's going to be some greater likelihood if there's truly this sort of like molecular progression that eventually becomes metastatic, at least to the neck. But again, I think, when we talk about the scare sort of like story to a general dentist, like find the way to diagnose cancer 15 years before the patient develops cancer, it's a pipe dream. Because even in the setting of a cancer, again, I don't want to get into it because it's a whole different talk and I'm not an expert on it, but anyone who's interested in and is not familiar with the term lead time bias, you have to read about it because it'll completely change the way you think about cancer statistics.
Okay. So the right time to perform a new biopsy on him, it really doesn't make a difference.
I won't obtain a new biopsy until I see something look different.
Okay,
That's my
so-
personal. 10 years later, the person now continues to smoke 2 packs a day, is the same lesion.
Okay.
It just keeps changing clothes, but like masquerading itself really well. It's possible, but biology doesn't really do that.
So you wouldn't wait and see something
No matter what,
change,
every
like-
year or every 2 years, there are people will do that. And sometimes, sometimes you just have you work based on not like your gut necessarily, but you don't necessarily make the exact same decision with the exact same patient every single time. And
And
maybe of this patient, it's like, you really put a lot of emphasis on the patient to stop smoking, and they didn't stop smoking. And maybe as a result of that, it's opened up another discussion, and then it's been 3 years, and it's like, we should really get another biopsy. Or maybe the first biopsy was obtained somewhere else, and let's just confirm. But if I have pictures and I'm convinced that it hasn't changed, that's why like the woman I showed you who had the ulcer with all the proliferative leukoplakia on the tongue and then the subsequent follow-up with the tongue much more white. It's just because as it's gotten more white, it's like it may be like 2 to 3 years. Like, let's get another biopsy. And it didn't show anything different. And it's very atypical, but it's a homogeneous atypical. So it's not like oh, that's the area I'm worried about.
Okay, thanks for your answer.
Good question.
So I just want to add something from Gabriela's question. If you do an excision of a leukoplakia and after a few months it recurs in a similar way as the first one, would you remove it again?
Yeah, so it's one of the things that, at least from like a practical approach, I learned from Suk when I trained with her, just listening to her. We always talked about we're not necessarily like overly aggressive, like that one I showed you where I had the very thin margin. Because if it's going to recur, it's not going to recur at the same size because you've removed the lesion, right? So I mean, it's going to recur somewhere centrally. You don't want to see that. You see the patient right now, there's this like little white lesion, well defined. But the nice thing is at that point, when everything's healed, they have no scarring, but now there's a new little white lesion. I can do half the size of the initial excision, but have almost a full centimeter margin. So that's been my approach, and I can't tell you that I have lots of cases where it's like, oh, and then I did that another time, and another time, and another time.
Yeah, I have been questioning myself about this question about removing or not, and performing surgery or not, because we have some few cases that we have done that, we have removed it every time it recurred, and eventually progressed to cancer.
Yep.
So nowadays I keep thinking, should I have removed it, or
No,
should I have it?
but it's a really good question. It gets back to that. So I don't know. In English, we have a term, and maybe it comes from another language. Don't poke the bear.
Yeah.
Right? Bear is hibernating asleep. Like just leave it alone. It gets back to what I was saying. Right? Maybe just the healing, all that all that activity, proliferative activity, somehow each time it comes back a bit stronger. We don't know, but I agree, and that's the problem with not having data, is we do something that seems like the right thing to do, but it may be that each one is not the same. So if you can pick the right one, it's like, oh, surgical treatment's the best thing, and it actually will somehow keep it from coming back. And another one, because of some other characteristic, now, if you surgically excise it, based on the molecular changes of the margins already, this thing is just going to blow up.
It goes back to our discussion yesterday about the erosive implants and inflammation that could be
Exactly.
from tumor or
Exactly. So I try not to swing too hard towards anything that's theoretical, because at the end of the day, it's just your own bias. It's leading you forward in some direction.
Thank you.
And we also had cases in which initially the patient had a proliferative on the palate, and we proceed with total removal and no demonstration. And then after 2 years, the transformation occurred, and the other side
Yeah.
and retomolar.
Exactly.
So
Exactly.
it's
So
impossible to assure that the
I think that's one of the most important takeaways. Like a patient who has proliferative leukoplakia, they're at risk for cancer, but it can develop anywhere. So you could try and remove everything, but it's like the risk is there, and it can just develop. It's frustrating. But I think so, and it's part of why I just don't get too excited about the field, because when you have that type of a biological system, imagine how complicated it's going to be for us to ever be able to approach it in like a really logical, directed way. No, it's going to be, do we do 3 months or 6 months, and we examine the whole mouth really well, and we look for a cancer, because now this is a patient who should be screened for cancer, not just sort of once a year come in and see the dentist. And even then, so if you miss the cancer, it's 3 months later, not great, but also hopefully the patient's aware enough. It's like, everyone's been making noise about funny stuff in the mouth. You'd think that if now all of a sudden it feels funny when you swallow on the other side, maybe you wouldn't wait 6 months to tell your doctor about it, right? So again, I think, some of the onus goes on the patient too.
As you said, very frustrating.
Yeah. or you accept it for what it is, and you focus on all the other things that you can do very effectively within your practice, and you treat these patients because they need to be treated, but you just don't let yourself get too frustrated, because you're still managing. I mean, you're going to manage these patients better than anyone else in the system can manage, right? And I say we, like any of us, anyone who's had the training, regardless of what bias you have, unless you cause way too much harm for all your patients because you're so crazy and aggressive. Beyond that, I think everyone's going to manage the patients well.
Questions?
Regarding the proliferative vertical leukoplakia, we don't have the clear algorithm for management as you show it from Professor Van der Haan that everybody has been using so far. Could you do something different in the management of these kind of lesions? Because for most of the cases are impossible to remove it surgically. So
No, same thing. And I try not to see them too frequently because I think it just creates too much anxiety. So, most cases, I would say probably 6 months. But I have some patients where they've been so stable. And I'd say some of these are kind of unique cases, like patients who have had graft-versus-host disease have what looks like a proliferative leukoplakia. But I can say from experience, like, I don't want to say that there's zero risk, but these lesions kind of tend to just persist and not really do anything. They never show dysplasia, they just show hyperkeratosis, and I've seen them regress over time. So I have a handful of patients, just because of like the volume of patients I see, that are on an annual follow-up for multifocal leukoplakias.
you think for this kind of lesion, maybe some therapeutic agent may be interesting, like Nikimon or like a few, because
I don't think there's any way to effectively provide the treatment. I think it probably has to be a systemic therapy that would be effective, acting locally. The question is, what would that treatment be? And is the potential toxicity and side effects and long-term complications from it worth the risk when you can't actually measure the risk? Or is it better just to wait and treat cancer if cancer develops? I don't know. Because at the end of the day, the two things you really, you can look at quality of life. Some people, quality of life is going to be around anxiety and worry and whatever. You can look at cancer development. You can look at overall survival, right? I mean, at the end of the day, what most people care the most about is just how many more years am I going to live?
Yeah. I think it's a really difficult question that we're not going to have an answer.
Not in our
for
lifetime.
the time.
No.
It appears that both surgical or non-surgical treatments are not effective enough. In general, non-surgical treatments like Ligimod and others, retinoids and tests,
You get a
it's
short-term
effective
response.
for time.
You get a short-term response. When effective, it's effective short-term.
And
It's
then
always-
you stops and
Come back. Yeah.
Come back. The lesion recur. Or a lot of there's side effects.
Exactly.
Also. It's a general result for many times ago. I was remembering another study that is very interesting. The title was like leukoplakia, is that biopsy reliable? That showed is a very famous study that not always there is a correspondence among the biopsy and the surgical removal when the total excision
Oh,
is.
exactly. Yeah. Well, it's just because you have a lesion that's this big, and you take a biopsy here. Even if you take 4 biopsies, you still have 98% of the lesion that you haven't sampled. So we make assumptions, right? That this is representative, that's representative, but we try and pick the best spots. I don't use toluidine blue. There is some T blue in our clinic. I don't think anybody uses it on a regular basis. I don't like anything like that you just sort of use sometimes, you don't use other times. You don't really have an exact rule that you follow as far as what to do with it. I don't like things like that. And I've never felt that when I had a patient with a leukoplakia that I was struggling to figure out when, where, and why to biopsy. So And again, it adds time, and it also, I think with something like toluidine blue, you know, depending on the level of understanding of a patient, once you start introducing other things like this, you know, it brings up like, it potentially brings up questions that you don't have answers for. Even down to like, oh, but you know, the doctor who referred me to you and first did a biopsy didn't use it, you know, and it starts bringing up questions.
We don't use it too.
Yeah.
Here.
But I know, but there's, you know, even colleagues I have that use it, they won't, they'll be honest, you know, they don't use it in a consistent way. They pick and choose. So there's a ton of bias.
And what's your opinion about some systems like Bellscope and Visualize?
I don't really have any opinion. I mean, the you know, if you look at, you know, high level sort of reviews, systematic review, any understanding really to look at the science behind it, nothing's demonstrated any real benefit. Again, are there things that you could potentially demonstrate that show you something? Maybe, but does it help me better direct how and when I'm going to biopsy a patient, or how and if I'm going to diagnose a cancer? No, I don't think so. But I mean, there's not a whole lot of noise about any of these, you know, adjunctive aids anymore. I think everything is moving towards molecular. The problem is that, you know, there's no consistent molecular signal that actually tells us anything right now. But with time, and I'm sure there's tests. I'm sure there's somewhere you can send your tissue and get some sort of molecular, you know, profiling back and scare the hell out of your patient. But I don't know what you're going to do with the information. Right. And it'll cost someone something. So good uplifting afternoon, right?
No more questions? Anyone?
I think we're quite on the same page regarding
Yeah.
the way of performing the medical
Seria
patient.
uma área que tem maior risco de transformação quando tiver a lesão. The question.
The question is, when you see a lesion, do you have any sign for based on the clinical basis to decide what's the area with more potential for lymphoconsolidation?
Yeah, so I mean, obviously, if there's any red component, so it's purely white, there's also a red and white area. You've got to be looking at the red and white area. If you have an area that's mostly sort of smooth and homogeneous, and yet there's an area that's kind of gets nodular, your eyes have to be drawn to there. Maybe you go right to the middle of that. Maybe you get sort of an area that shows the nodular and the less nodular. I'm not sure you necessarily need like two separate biopsies. Obtaining a biopsy at the margin of normal to whatever the leukoplakia, in most cases I don't think is going to be very informative because we know what normal is. We know the margins are going to be positive no matter what, so that's not so interesting. But you know, like I showed that example of that tongue with the red and white lesion, and part of it was a little bit bulky. And I showed an example of getting 3 biopsies. So I do that. You know, I'm not going to say I do it regularly because there's only so often you get a patient like that into your clinic. But if I see a patient like that, you know, and I'm like, I'm not really sure it would be better to go here or there. I just see the patient, I think it'd be better to just get 2 biopsies. We're going to go through it anyways. Let's just do it now. Yeah, that sounds fine.
We attended the SUC talk in 2018 in Rio de Janeiro.
Right.
And she presented in some cases of this clinical presentation of ring around the collar.
Of what?
Ring around the collar.
Remind me what that is.
This is very interesting and appears to me to be an initial sign of maybe a PVL in the near future. And starting initial change, it's important to be aware of.
So you can scare it away before it starts.
Yeah. Of course, if there is no traumatic factor, it's something that I call the attention of our students.
Yeah, I mean, it's interesting. But I guess it's a little bit like, do you want to know if you're going to develop Alzheimer's disease or not? You know? Like, do you want to know? You can't do anything, at least today. So, But yeah, interesting.
I remember something that,
Fê, fala mais alto, porque eles não estão
okay, sorry. Not that loud. You mentioned one patient with BVL that showed eventually some ulcers.
Initially,
Initially.
so she had the extensive white changes, but
Mhm.
also in the setting of very active lichen planus.
Okay. But do you have any experience with other patients with BVL showing some ulcers at some point?
No, I mean it's not typically an ulcerative condition.
Because we are dealing with a patient, and I'm looking at Victor because he's helping me. She has these classic features of BVL, but at some point she develops
Ulcers.
Ulcers.
So I have it's all bias, so I don't like to say this too much anymore on TV, I guess. I think there's a lot we don't understand, and I've had this argument to some extent, even with sort of patients we've included in studies. When somebody presents like 4 quadrants, sort of perfectly balanced changes, not necessarily showing any actual dysplasia in biopsy, there's a chronic inflammatory band. Do we actually understand everything about lichen planus or lichenoid inflammation? Of course not. And this type of condition that you're talking about, I think that there are these weird situations where you have sort of a combination. It seems like the underlying driver is the sort of the lichen planus, lichenoid phenotype. But I have no idea. I have no idea, but at least it explains some of these weird phenomena when you see like what you're talking about.
So this patient is very challenging for us because she has these white lesions. They are increasing over time. They are always at the same spots. They are not changed. They are not dynamic. We do not see any classic sign of our lichen planus, but eventually she develops some ulcer in the right.
Within the white changes.
Yeah, exactly. And they respond quite well to steroids.
Exactly.
So we are always like, oh my God, this oral lichen
And it's not
planus are-
progressive, because if it was progressive, the ulcer wouldn't go away.
Yeah.
Like you have an ulcerative squamous cell carcinoma, you can't treat it with steroids and make the ulcer go away.
No, the ulcers, they respond quite well.
Yeah.
And
So I think there's some inflammatory component, but like, is it the same as somebody who has just idiopathic lichen planus? Seemingly no. But is it something about, I don't know, molecular changes that have already happened? Is it something about their genetic predisposition?
And
I have no idea.
concerned because we're treating with immunosuppressive.
Yeah, well, you're doing it short term when you need to.
We're dealing with her pain. We need
Yeah.
to
And you
address
kind of
that.
you got to be practical. We talked about it.
Yeah. Thank you.
Yep.
Any more question? Just a comment. You showed that diagram of recommendation for management of oral leukoplakia. Both professors were here
Oh, good.
at different times.
That's wonderful.
Tony Axel,
Really?
2002, I guess,
Yes.
and Professor Vandermaal, 2014.
That's awesome.
That's this room
Very nice.
talking to us.
There you go. I don't think they would have disagreed with anything I said. I hope, because I have the utmost respect. But I don't think I crossed them in any way.
It was very nice. It was very nice.
And I hope I didn't disrespect any of my colleagues either. Well, thank you for all the attention.
Yeah.
Wow, I'm really interested.